April 7, 1976. A surgeon in his mid-30s is scrubbing in for an operation on a boy 2 months shy of his 8th birthday. The child is suffering from a massive Wilms tumor. The mass has grown so aggressively that it has almost completely replaced his right kidney. This anatomical schematic shows the tumor pressing against the vena cava, the body's largest vein. If the surgeon manually grabs and pulls the kidney, the mechanical pressure risks pushing loose cancer cells upward into the bloodstream, seeding the disease. There is a secondary risk as well. The kidney is encased in a high-pressure vascular network. Cutting directly into this area to free the organ could trigger catastrophic hemorrhage. To save the boy, the surgeon cannot attack the tumor directly. He must execute an outside-in strategy, meticulously establishing a safe perimeter before he ever touches the kidney. The operation begins with a wide chevron incision across the abdomen. Immediately, the surgeon visually inspects the liver to ensure there are no signs of metastatic spread. Finding the liver clear, he palpates along the great vessels, verifying that cancerous nodes have not spread outside the immediate zone of the kidney. The team then begins separating the digestive system from the surgical field. They divide the peritoneum and peel the entire right side of the colon away from the tumor. They carefully mobilize the duodenum, ensuring the gastrointestinal tract is completely unattached from the kidney. The tumor detaches easily from these structures, showing that the cancer hasn't directly invaded the adjacent intestinal walls. By completing this clearing phase, the surgeon has narrowed the threat strictly to the kidney itself and its direct blood supply. Now, the team shifts into the primary danger zone. They dissect straight down the right lateral margin of the vena cava. Navigating along the margin, they identify the right renal vein, the primary outbound channel connecting the tumor to the main circulatory system. Through very careful dissection deeper into the tissue, they reveal the hidden right renal artery. This diagram shows the sequence. The surgeon ties off the inbound renal artery first, leaving the outbound vein open. Stopping inbound flow prevents pressure buildup. With drainage continuing, the vascular tumor begins to shrink. Finally, the surgeon ligates the renal vein, severing the organ completely. The team clears the final structural tethers by dividing and tying off the vascular plexus surrounding the right ureter. With the blood supply neutralized, the kidney, the adrenal gland, and the massive tumor are lifted from the wound as a single contained unit. A single suture of 6-proline is placed to control the final minor bleeding point on the vena cava. By cutting the lifelines before ever mobilizing the organ, the surgeon neutralized the risk of hemorrhage and metastatic seeding. On the back table, the extracted mass is cut and inspected, confirming that the Wilms tumor had totally consumed the kidney. Before closing, the surgical team shifts their focus to the opposite side of the abdomen for a final safety protocol. They mobilize the left colon and strip away Gerotis fascia, the protective connective tissue, to grant full visual access to the left kidney. After a thorough palpation, the surgeon confirms the left kidney is clean and free of any spread. The organs are tacked into place, the wound is irrigated, and the muscle layers are closed. No surgical drains are necessary. The recovery of this 7-year-old boy highlights the effectiveness of this methodical isolation. By establishing a perimeter and cutting the blood supply before ever touching the mass, the surgeon ensured the tumor was neutralized before it was ever moved.